Welcome to everybody. A very warm welcome to everybody who could make it today. And yeah, today is our fourth scientific session here related to troponin in this case. So we had already three other sessions here. So this is now again on troponin. So yeah, thank you all for joining this interesting session here. So first of all, a very few words about our presenter for today. It's Dr. Johannes Neumann. Thank you, Johannes, that you can make it for us today. And yeah, we are really looking forward to your very exciting and interesting presentation. So Dr. Neumann is the senior consultant for cardiology, doctor of medicine, and he is also assistant professor at the UKE. It's a university hospital in Hamburg, Eppendorf. So, and more than that, he is an adjunct professor at Monash University in Melbourne. Okay. So, but of course, he is also responsible in his daily business or daily job for the emergency department and chest pain unit at the UKE in Hamburg. So maybe all of you might remember that the researcher team around Johannes and Professor Blankenberg and others, this team a couple of years ago evaluated our PATHFAST system for the 0-1 hour algorithm, which then in the end also leads to the fact that we were listed in the European Society of Cardiology Guidelines. Okay, so that was a great work and a milestone for PATHFAST diagnostics, of course, right? So regarding the content of this presentation from Johannes today, we will learn something today about the relevance of the acute chest pain. You know, he will also give an introduction, a short introduction and information about the high sensitivity cardiac troponin and its options and possibilities with diagnostics. We will learn something about the 0-1 hour algorithm already mentioned by me, you know, itself, with a slight focus on PATHFAST, of course, and more than that, we will have an insight from Johannes into novel diagnostics concepts. Okay, so that's all from my side, and now I would like to hand over to Johannes. And yeah, please, Johannes, start your presentation. Thank you very much.
Thank you, Frank, for the excellent introduction and for the very kind words. And dear audience, it's my great pleasure to give this lecture here today, talking about cardiac troponin, which has been a very intense focus of my research in the past 10 years. And I'm happy to share some of these experiences with you and look forward to a lively discussion in the end. So these are my disclosures related to acute chest pain and cardiac troponin. As Frank already mentioned, I'm responsible for the emergency department and with a focus here on the chest pain unit. And indeed, chest pain is a super frequent symptom. And approximately 5 to 10% of all patients presenting to the emergency department report about acute chest pain. And of course, not all of these patients have acute myocardial infarction. And there are many, many reasons for acute chest pain. And some of them are listed here. And of course, you are not expected to read all of them, but it just should illustrate that such a diversity possible causes for acute chest pain. And I've highlighted the acute coronary syndrome here as being one of the most relevant acute diseases and the one which we're focusing on today. But among these possible causes, how do we separate the chaff from the wheat? And this is the clinical challenge which every physician in the emergency department has to deal with every day. And the ultimate aim is to start with the population of suspected myocardial infarction and then distinguishing those where we can rule out acute myocardial infarction and aim for a discharge of the patient and aim for outpatient care, and rule in on the other hand. So I want to identify those who are actually at high risk or who have acute myocardial infarction, and we want to treat those according to the guidelines, potentially do a coronary angiogram and plan a hospital admission. And this is the key step which we're doing in the emergency department. And what is the concept that we're using for this on a daily basis? And this is actually a stepped approach. So we're starting in the very top row with the clinical symptoms and the vital signs. And this is, of course, a rather weak or subjective aspect, but symptoms can be less risky of acute myocardial infarction. They can have a low risk, for example, if you have a very localized pain, or it can be very, very high risk, for example, if the patient has a shock and is undergoing CPR, for example. The next important tool is the ECG, and this is clearly indicating acute ST elevation as a clear sign of acute myocardial infarction. So on the very right-hand side, we do have a very clear pattern where we do not need any further diagnostics, and these patients should immediately undergo coronary angiography to open the likely occluded vessel. But in all other cases, we do need further information, and this is where cardiac troponin comes into play. And we'll be talking about cardiac troponin on the next slide in greater detail. But the basic concept is already illustrated here, that those with a very low concentration can be eligible for rule out of myocardial infarction. Now, cardiac troponin is a protein complex. It's shown here on this slide on the left-hand side. It's consisting of 3 subunits, troponin I, C, and T. And cardiac troponin I and T can be measured in peripheral blood. And usually cardiac troponin is released into the bloodstream following acute myocardial infarction, which is illustrated here. So we have a coronary artery, and when this is occluded by a thrombus formation, the cardiomyocytes, which are peripheral of the occlusion, they die, and due to this ischemia, troponin is released into the bloodstream. And this is what we can measure then. And with a older generation of cardiac troponin assays, which used to be sensitive troponin assays, we could measure the tip of the iceberg, the substantially elevated troponin concentrations. But using higher sensitivity troponin assays, we're now able to detect very low concentrations of troponin. And as this is released into the bloodstream following the acute event, we use a serial measurement in the blood. So as Frank already introduced, the 0-1 hour concept, which is illustrated here. So we measure troponin directly at admission and repeat the measurement after 1 hour. And the change of this concentration is then interpreted as a delta change of troponin. And this is what is clearly recommended in the current guidelines by the European Society of Cardiology. And so we start with a population of suspected non-ST elevation MI patients. And on the left-hand side, we do see highlighted that those with very low troponin concentrations or a low concentration, but no delta change after 1 hour, they are eligible for rule out, while those with high concentrations and a high troponin delta within 1 hour are eligible for rule in. All others remain in the observe zone. And based on this triage, we then have the further disposition, so discharge, admission, or coronary care unit and coronary angiography. Now, what are the exact cutoff concentrations? And this is a very busy slide, and of course, you're not expected to read that, but it should illustrate that for each troponin assay, the guideline recommends very specific cutoff concentrations, which should be used to be considered as very low, low, no 0-1 hour delta, or high concentration, or a high 1 hour delta. So a very complex table, and you really need to be aware of which troponin assay you're locally using. And based on that, you can look up the exact recommendations. But the question is, what is actually the evidence for the ESC 0-1 hour algorithm? And here we performed an analysis using a very large data set of more than 4,000 patients. And we looked at the cardiac troponin T and the cardiac troponin I assay. and found that it was a very efficient way. It was able to rule out acute myocardial infarction in a high proportion of patients, and only very few patients with myocardial infarction were missed. And the negative predictive value here was 99.7%, which is super high and very, very safe. And on the other hand, on the high-risk arm, the positive predictive value was 62%. So in other words, the likelihood was 62% that those which were classified into this group actually in the end also had an acute coronary event. Now the question is it only relevant for the acute decision, or is it also prognostically relevant? And this is shown here, and we could report in earlier studies that indeed those which were classified to the low risk group, so shown in green, had a very low incidence of all-cause mortality after 1 year of only 0.8%, while those classified to the observed zone, shown in yellow, had a 7.2% proportion of mortality after 1 year, and this was 10.4% in the high risk group. So this triage, which is done in the emergency department, also has a strong impact on the prognosis after 1 year. Now, this is all retrospective analysis, and the question is it also in the real world setting? Does it really work here? And this is data from Basel, from a cohort here, 2,200 patients, and they really performed all the recommendations based on the ESC 0-1 hour algorithm, and they could confirm the very good diagnostic performance and could reduce the stay in the emergency department, which was in median only 150 minutes. For those of you who've worked in the emergency department before, you'll be aware that this is a very short period of time for an acute setting. The question is, can we rule out myocardial infarction perhaps even faster? And this is data from Edinburgh, from a cohort here, 22,000 patients with suspected myocardial infarction, and they looked at only a baseline troponin concentration. So no serial testing here, just one concentration. And shown on the x-axis are the rising troponin concentrations, which were used as thresholds. So everything below this threshold was considered to rule out myocardial infarction. And on the y-axis, you see the associated negative predictive value. And the authors reported that actually all concentrations below 5 nanograms per liter, here troponin I in this case, using the Abbott assay, that those patients had a very low risk of having acute myocardial infarction. But now this is all based on assays which run on a central device in the central lab. And the question is, can we improve the process? Can we be even faster than what I've shown you so far? And in this regard, let's take a look at the usual workflow for our patients. The patient is usually brought by the ambulance, transported into the emergency department, and this is where we do the ECG right away. And then we measure cardiac troponin, which is sent to the central lab, and this introduces a delay in time. It should be approximately 1 hour turnaround time. This is what the guidelines recommend. But from my clinical experience, I can tell you that this is usually not achievable in most hospitals, and in some hospitals will take even substantially longer. And this is where the point of care system comes into play, because the point of care system really allows you to do the testing immediately at the point where you need it in the emergency department. And using such a device, measurement can be done in less than 10 minutes. So the decision can be made much faster. And now I'd like to talk a bit about the PATHFAST system, which we evaluated in a prior study. We first looked at the assay itself to evaluate whether it's a really high sensitivity troponin assay. And this is data from a general population, so 474 patients, or individuals, not patients. We determined the 99th percentile and looked at the proportion of detectable values above the limit of detection, and that was about 80%, which really is a very high level and definitely qualifies this assay to be seen as a high sensitivity assay. We looked at the 10% coefficient of variation, which is an important measure, and this should be below the 99th percentile. And indeed, it was found to be at 11 nanograms per liter, which is below the 99th percentile of 28 nanograms per liter. And now we then went one step further and measured troponin concentrations using the PATHFAST device in our cohort study, the biomarkers in acute cardiac care study. And here we looked at a large population. We started with a derivation data set, so 669 individuals. And here we derived cutoff concentrations based on the performance, aiming for a high negative predictive value and a high positive predictive value. We identified the concentrations of less than 4 nanograms per liter, as a very low concentration, or a delta of less than 3 nanograms per liter to rule out myocardial infarction. And on the other side, a concentration of more than 90 nanograms per liter, or a delta of more than 20 nanograms to rule in myocardial infarction. And we then looked at the second population, so a validation data set of more than 600 individuals. And here we confirmed a very high negative predictive value of 99.6% and a positive predictive value of 85%. So an excellent diagnostic performance. And this indeed was the basis for the recommendations in the ESC guidelines. And these are the concentrations which I've shown you earlier. So, but where can we use point of care troponin? Now, we've talked about the emergency department. So here it is definitely of use, especially for those cases where you really need an urgent decision. So you have perhaps an unstable patient which does not show clear ST elevation MI, but you really are concerned on the further diagnostic which you may need. And here the point of care will provide valuable information in rapid time. But it will also be valuable for hospitals who do not have a central lab available, so who would need to send samples to a laboratory outside the hospital, and here will definitely be valuable. And finally, an outlook is focusing on the pre-hospital care, for example, in the ambulance or in the outpatient setting. So a patient presenting to a general practitioner and then measuring troponin with a point of care assay. Now, I've talked a lot about algorithms and 0-1 hour concept and specific concentrations, but what else is on the horizon in terms of acute coronary syndrome? And this is the area of personalized diagnostic approach. And here I would like to share with you some insights, some thoughts on how we think this field will develop further. So currently we're using this category system where we're classifying patients into 3 risk categories, but this is somewhat arbitrary because we cannot put each individual into one specific risk category. And the ultimate aim is to have an estimation of an individual MI probability. So why needing to categorize when we can have an accurate individual estimation of an individual having acute myocardial infarction? And this is where we started the Artemis study. Artemis is an acronym for Artificial Intelligence in Myocardial Infarction. And this is a global study which was led by myself and Raphael Twerenbold in Hamburg, but we included researchers from all over the world who contributed their data and their input. And what we did here was we used a machine learning approach. We had a lot of input in terms of clinical variables, but also laboratory information and imaging variables. And then we had the machine learning algorithm, which identified the most important variables of interest to discriminate patients with myocardial infarction and those who do not have myocardial infarction. And these are the variables which were identified by the machine learning algorithm. So I'll perhaps read them out loud because they are important. So it was age, sex, heart rate, troponin concentration, measured twice, so at admission, a serial measurement, and the time between both measurements. Smoking status, dyslipidemia, ischemic signs on the ECG, family history, and symptom onset. So all this information was then aggregated into one specific estimation of an individual and determining the probability of having acute myocardial infarction. And you'll be aware that all these variables are readily available in the emergency department. And how do we envision the clinical application of such a concept? This is, for example, using a digital application, which we're currently developing and planning to certify as a medical device, which then allows to input all this information. The machine learning algorithm does its work and then comes up with a specific estimation of MI probability. But now with this, I would like to conclude this lecture. So I've shown you in the past slides that high sensitivity cardiac troponin is the gold standard biomarker for suspected myocardial infarction. Established algorithms like the ESC 1-hour algorithm provide a very high diagnostic accuracy and allow for a fast decision making. Point of care tests will further speed up this diagnostic process and do offer new perspectives to be used also in outpatients, for example. And finally, there are novel approaches being developed which use machine learning, and these will in the future individualize the diagnostic steps. So with this, I would like to close my lecture and would be happy to take your questions.
Yeah, perfect, Johannes. So thank you very, very much for this excellent and very, very educative lecture from your side. So as always, I just want to open up now our question and answer session. So just for your information, you have two ways to address your questions now to our presenter, Johannes. So you can either use your chat function, Zoom chat function, or of course, maybe even better, you can directly address your questions now verbally to Johannes. So please feel free to state every question that comes to your mind. Okay, so I found one question in the chat. Okay, so my question is the following. Clinicians in my country often prefer to stay with conventional 3 hours and 2 hours also algorithm. Many of them do not see clear clinical benefits and significance of a rapid algorithm. According to your experience, what are specific clinical situations where 1 hour algorithm can be especially advantageous and clinically superior? Maybe you even have a head-to-head comparison data. So it's all around the benefit of the 0-1 hour algorithm directly compared to the formerly used one, 0-2 and 0-3. Johannes, what do you think about this?
Thank you, Frank. Yeah, Olga, excellent question. And this is what we're very frequently being asked. So the very specific benefit is that in a very busy emergency department, you can make a decision after 1 hour already. So we are usually overcrowded here in our emergency department. And whenever someone comes with chest pain, we need to monitor them and take a close look at them. So every hour is very valuable here for us. So in case we do not have to observe an individual for 3 hours or even longer and can already make a decision after 1 hour, this is super important for us. And this is what we found very valuable. For the 3-hour protocol, actually, there are indeed comparisons. There's a number of studies which have compared the ESC 0-1 and 0-3-hour algorithm. And with the 0-3-hour algorithm, you will never achieve such a high negative predictive value as has been done with the ESC 0-1-hour algorithm. So it is indeed safer. There's also been voices that said, but then you're doing many more coronary angiographies because you're looking at lower concentrations. But this is indeed not true, and prior work have shown that the number of coronary angiographies does not increase using such a rapid algorithm. So yeah, it is indeed safer and more efficient.
Okay, yeah, very interesting. Thank you very much, Johannes. Maybe I can directly add a question from my side, just to have your valuable opinion here on this topic, Johannes. So more and more people, or more and more also key opinion leaders, seem to favor the 0-2 hour algorithm. So I hear from time to time that it's not really feasible in a really overcrowded emergency department sometimes to follow the 0-1 hour algorithm. Is there really a trend? Maybe what do you think, Johannes, for this 0-2 hour algorithm more and more, recommended and talked about?
Yeah, maybe this is sometimes a misperception, because the concept of the ESC 0-1 hour algorithm does not specify that you need to have the result of the first measurement already available. This is what often is stated, that the turnaround time for the troponin is above from 1 hour, and therefore people state, you can't do the 1 hour testing because we do not have the 0 hour testing. But of course you can draw blood after 1 hour without not knowing the first troponin result, and then after 2 hours you'll have the total findings already available. So this is definitely possible, and I would argue that it should be possible to measure troponin, to draw blood after 1 hour, if it's possible to do that after 2 hours. So that's definitely should be possible. Okay. But of course it addresses one problem, that in the clinical setting it is difficult to really adhere to one very specific time point. Usually the nurse will not sit on the desk and say, when is it time finally for, when I have 60 minutes lapsed, I'm just waiting for that one troponin to draw the blood. But they will just do that whenever they are free, and it's around that time. But this is also which will be addressed in the future using artificial intelligence, where you're not fixed to one specific time point, but can draw a serial measurement whenever it's possible for you, and the algorithm will interpret will take this into consideration when interpreting the troponin concentrations.
Wow, interesting statement. Yeah, thank you, Johannes. So I'm just asking you, because we decided in the past also to get PATHFAST evaluated with a 0-2 hour algorithm. This is shortly to publication already now, and that was just my question. What is the benefit? But now you explained perfectly. Thank you. So, and you just touched the topic slightly, Johannes. The next question is indeed about artificial intelligence, as if you guessed it already. So the question here in the chat is, you mentioned the artificial intelligence for rule-out AMI. Is it already validated on a clinical trial with real patient? What about the clinical sensitivity here, Johannes? What is your experience? What are the data available so far?
So yeah, we published the manuscript 2 or 3 weeks ago. That was based on 25,000 individuals, all patients which were recruited with suspected myocardial infarction. And so this is indeed a lot of data showing how the algorithm works and how well the discrimination performs. The clinical sensitivity is really a difficult topic, or not a difficult topic, but we're not talking about one specific cutoff here anymore. We're just determining the individual probability of having acute myocardial infarction. And then you can decide on your own which threshold you want to set. So you can say, and that's what we did in the publication. So to rule out acute myocardial infarction, we want to set a threshold of a MI probability of less than 0.5%. So we were very conservative and looked at a very low risk population to rule out acute myocardial infarction. And here the negative predictive value was 99.6% or something around that, which was comparable to the ESC 0 hour approach. But importantly, this concept applied to approximately 3 times more patients compared to the ESC algorithm. So it was very, very more efficient than the current approach which we're using.
Okay, thank you very much. Very interesting. I have another question about PATHFAST at your site, at your emergency department. It's like, are you currently using PATHFAST there in your emergency department? If yes, which lab instrument did they compare it against? I mean, I know the answer, but please, Johannes, go ahead.
So we measured the samples in stored blood. So we measured with PATHFAST in stored blood samples. So we're not using it on a daily basis in the emergency department. Here we're evaluating a different point of care device.
Okay, perfect. Okay, I have something here, but I cannot really understand. It said Artemis approach compared to the methods currently used nowadays. Okay.
I think it's linked to the first comment. So the main advantage, perhaps I've answered that question already in my prior answer. So the main advantage is indeed that it's substantially more efficient than using the current guideline approach. And I mean, you can explain that very, very easily when you consider that troponin concentrations are clearly associated with age. So the higher the age, the higher the troponin concentrations. But this does not indicate that someone was aged, I don't know, for example, you have an individual aged 30 years, and he has a troponin concentration of 2. The same individual aged 70 years may have a troponin concentration of 7. Which both will be normal for the individual because there's a linear association of troponin with age. But this is not recognized in current guidelines, where you have a threshold of 5 nanograms per liter to rule out acute myocardial infarction. But using a machine learning approach, you can take this into consideration and, so to say, adjust the troponin concentrations for the relevant confounders. And age is just one example. It also applies for sex, for example, as males have higher concentrations than women, individuals with hypertension have higher concentrations, and so on and so on. And this is the key advantage, and it results in an increased efficacy.
No, exactly, Johannes. I also really like this kind of personalized aspect that comes into play here. This is indeed what you explain, really, really interesting and beneficial. Yeah. Okay, so any other questions? So I do not see any other questions here in the chat. Only one. Sorry. In clinical routine, how important is it to use age-adjusted cutoffs? Okay, what's your opinion?
Short answer: it's not recommended in guidelines, and there are no validated data to use age-adjusted cutoffs.
Yeah, I can also confirm this from the IFCC committee. I'm joining every day, or not every day, every time with Fred Apple and his colleagues. So they do not really follow up this idea with age. With age-adjusted cutoffs, right? Okay. So any other questions? Just feel free to state any question. We still have some time. You can also address your questions, of course, verbally. You do not need to use the chat function. Okay. I have one question, but it's a more practical question about the recording of this webinar. I can answer shortly this one because yes, this presentation will be available. We will put this on our product portal or somewhere you can easily access to. Okay, product portal is the location of choice here. Okay. So, are there any other questions? Okay, if there are no more questions for today, I would really thank everybody for joining our webinar. The next webinar, by the way, I can shortly mention, will be next quarter. The topic here will be then again sepsis related. We will have a topic for Prisepsin in neonates. So this is the plan for our next webinar, a more sepsis related topic then. Okay, but we will inform you all in time, of course, about the content, presenter, and time point and schedule. Okay. Okay, then thank you all very, very much for your participation, and Johannes, of course, again, for your excellent presentation. And yeah, then I would like to close this webinar for today. And yeah, thank you for joining, and hopefully then see you next time for the next webinar. Okay. Goodbye.
Thank you very much.
Thank you so much. Bye-bye.